Um, Hello, everybody. We're ready to start the program. I want to thank everybody for being here today. And again, thank you for the people who are watching on the Horizon House television. We are pleased to present this program. Wellness Committee is sponsoring it. You see the title, Medicare Now and Into the Future. And we are very fortunate to have the State Insurance Commissioner with us today, Dr. Mike Kreidler. And also we have Tim Smolen, who's the director of the SHIBA program, which is the acronym for the State Health Insurance Benefits Advisory. I think I got that right. Dr. Mike Kreidler has been has been in state involvement here for at least 50 years. He's served various positions. He was a member of the House of Representatives in the U.S. Congress, and he's been our state commissioner for 22 years. And during his tenure as state commissioner, he has been working with several programs that have enhanced our insurance in this state. He's always been an advocate of consumer protection and an advocate for healthcare benefits and healthcare reform in this state. Today, our format is going to be that we'll have about a 30-minute presentation by Mike and Tim, and then we'll have time for a 1-hour question and answer period. And I hope that this will be useful for you in terms of understanding Medicare now and what we can expect in the future. So at this point, it's my great pleasure to introduce Mike Kreidler, who is a long-term friend of mine and our insurance commissioner. Mike.
Thank you very much, John. And it's a pleasure to be here and have had lunch with you and Mary Ann. And then to run into a longtime personal friend of mine, Seth Armstrong, served together in the Washington State Legislature together a number of years ago. It's kind of like, yeah, John's absolutely correct. I've been at this for a while and I love public service. I love having a chance to interact with people and try to address issues. John and I were undergraduate roommates, and then I was best man in their wedding some 51 years ago. So we go back a number of years, but we had a number of conversations about healthcare and about the delivery of healthcare and how the weaknesses in the so-called the American healthcare system as to what we could wind up doing and to make changes. And, well, John went on to become a doctor of psychiatry. I wound up being a doctor of optometry, but then also picking up a master's in public health with the idea of being very involved in looking at the issues and challenges of public policy. And lo and behold, went to work for group health and had a chance to work my way into elective office, from starting with the school board and state house, state senate, and then eventually to Congress. Then I was appointed by President Clinton to the position of regional director for the U.S. Department of Health and Human Services. After a less than pleasant separation from public service in '94, along with a lot of other Democrats, and I wound up then having a chance to do that in working for the public health and health and human services. But recently, for 22 years now, longer than any other person in the country, serving as an insurance commissioner. I never thought I'd stay that long in that position, and much less to become not only the most tenured of the insurance commissioners in the country, but on top of that, to have the challenges of not only being very, very tenured in the position. We need to have both mics, I take it. It was certainly having the chance to also, or I couldn't call it an opportunity, but when you started to look around among your fellow commissioners, not only had you been there a long time, you were the oldest insurance commissioner. So not only did I outdo them in tenure, I also hit them in age. So I was one of those where I could look back with pride. But the duties and responsibilities as insurance commissioner is something that really brought me together with a number of the things that even John and I talked about so many years ago about how we could maybe influence what we could do with our healthcare system. Lo and behold, President Barack Obama was successful in doing what nobody else had done, and that was to pass the Affordable Care Act, and having its the implications of that, and being able to get that introduced and implemented in this state as aggressively as we possibly could and as favorably as we possibly could became one of the major challenges that I certainly experienced in this job. But the position here of dealing with Medicare is somewhat kind of interesting. It is one where we actually get federal funds, some federal funds, to assist us to do outreach with people to help them understand what is available in supplements in addition to Medicare, and specifically what is Medicare coverage and what it doesn't cover, what your expectation should be. So we have a SHIBA program that John mentioned, and Tim Smolen is going to come up and talk to you about here in a bit and take the questions that you might have. But it became one where we were actually, as a state, I don't know if any of you remember a former insurance commissioner by the name of Dick Marquardt. Seth will remember him, Dick Marquardt. I overlapped with Dick Marquardt as a legislator for all 16 years that he was the insurance commissioner, but he instituted a program of providing assistance to people on Medicare and the Medicare supplement, and understanding how what their choices were and how it worked. But we were the first state to implement it. And I can remember when I first got elected as insurance commissioner, Jim Long, who was the insurance commissioner from North Carolina, came up to me and he says, you know, I took that program and introduced it in North Carolina. I thought it was the best thing that you could possibly do to help consumers really understand what their choices are. And after that, after he'd incorporated what we were doing already in the state, because he'd been a long time serving insurance commissioner, it wound up then being funded by the federal government to have funds that would go to the individual states. So 2/3 of the funding is federal dollars. A third comes from my budget to try to help people really understand what's out there, what's available. And it is clearly one where confusion reigns. And that's why it's so imperative that we be out there and providing information to people. I remember one time speaking to the Yakima Rotary Club, and just as I was in the process of leaving the room, I'm always a little nervous when I'm leaving and somebody behind me starts yelling, you know, Commissioner, I got a question for you. And I'm going, geez, now what's kind of turned out to be a retired, just recently retired surgeon in Yakima, who said, I went through that SHIBA program. It's the best doggone program I've ever had. And I said, well, yeah, that wasn't too bad getting waylaid with somebody that's going to ask you or point that out to you. But it really tells me just how valuable it is for people to have that kind of access to that kind of information. Let me also point out that we operate with over 200 volunteers around the state of Washington. We would certainly very much appreciate if anybody has an interest in becoming a volunteer. It is, you become an expert, you get a credentialing to being an expert and providing assistance to people. It's not a full-time job. It's one of those where you volunteer and have that kind of interaction. And we've become much more adept, as Tim will point out, at doing it virtually than we've ever done before because of COVID and because of just the interaction of what we've grown to become used to. But in total, this is a program that can provide valuable input to you, to answering your questions about what is involved with the SHIBA program and the advice that we can offer. And if you have additional questions, don't be shy in reaching out to us, because we have people like Tess here who will be glad to help you answer those questions. And again, we have a lot of volunteers that are out there also providing assistance. It's a great way of giving back if you have an inclination to be in this kind of niche world of understanding what the Medicare options are and how we can all work together to make sure that we're sharing that information as much as we possibly can. With that, I'd like to turn it over to Tim and give you a chance he'll do a short presentation, and then he's going to take Q&A. And if we run out of time, don't be shy. We've got a direct number that you can call us, and unlike so many other numbers that you call, we actually have live people that answer the phone. Drives me crazy, but we have live people that answer the phone in all cases. So we'll be there to help you answer the question. So with that, thank you very much for the invitation and a chance to be here with you all, and a chance to get together with some friends too is much appreciated. So thank you.
That's great. Yeah, thanks, Devin. Risa, thank you. The folks who are managing the facilities, appreciate that a lot. So what I'm told from John and Jim is that what we have is live program today, and then it'll be broadcast in real time on CCTV and then recorded for YouTube. So I will try to manage my sense of humor a little bit and not say something that would embarrass my mother today. It's been a couple of days since I looked at this program that I wrote, so I have it here in front of me, and I'm going to try to hew to it pretty closely. But mostly, the reason that the commissioner and Tess and I are here is just really to answer any questions that you have. So this program is really just meant to provide kind of an overview of some of the things that I think are interesting and important about Medicare right now, and my own sort of crystal ball about where we're headed. But really, the main thing is just that it has to be worthwhile to you. And so we want to have ample time for questions and answers or personal conversations after the fact. So let me just start by thanking John and Marianne for their hospitality. We had a beautiful lunch together in the dining room. This is my first time at the Horizon House, and I'm really very impressed with the hospitality and the programming that you all are offering. So I hope that we kind of live up to your high standard and don't disappoint this afternoon. So as the commissioner said, I'm Tim Smolen. I'm the program manager for the SHIBA program. We were the first SHIBA program in the country more than 40 years ago. And now there are programs like ours in all of the states and territories. And we all, kind of meet together and talk about the challenges and opportunities of doing this kind of work, which we all find exceptionally rewarding. And so I'm really happy to be here today with you. And Risa, can we go ahead one slide? As the commissioner said, most of the work of the program is done by volunteer advisors. We contract as the insurance commissioner's office with 16 local not-for-profit organizations in King County. Our local partner is Solid Ground. You might know them as Solid Ground, or if you've been around a little while, they in a previous incarnation, they were the Fremont Public Association. And, so their mission is about ending poverty and helping people in the communities who need that. And they're a terrific partner for us today. And then my friend Tess Alemu is with us today as well. Thanks for being here, Tess. Okay, next one. I'm going to just give you kind of an overview. The next couple of slides are just an outline for the program, so you have a sense of where we're going, what you can expect today. So I'm going to just briefly describe kind of the purposes of the Office of Insurance Commissioner and what consumer protection means for us these days, what the SHIBA program does to promote the mission of the OIC and how we accomplish that work. And one more. And how's the volume, Devin? Am I okay for volume? Okay. And then what are contemporary challenges that we have? Of course, right now, we're kind of right in the middle of the annual Medicare open enrollment period. So some of you maybe have specific questions about the plan that you're enrolled in or other options out there. And then there's some sort of near-term challenges on the horizon. I'm sure you're aware of the Inflation Reduction Act that the Congress passed and the president signed. And you may be aware that we're anticipating the end of kind of the special authority that the president and the governor and local health departments have related to the public health emergency. And that will affect, all of us, but especially those of us who receive insurance through the Medicaid program as well. And in my estimation, we're still very much coping with the fact that COVID is a reality, right? We had to screen in today and wear a mask today, and we are still seeing everyday hospitalizations and deaths from COVID. And I just think it's just really important. And John is obviously mental health professional, but as an amateur, I think we can't underestimate the significance of the collective trauma that we've all been through with the global pandemic. And I think that's just important conversation for us. And I'll talk a little bit about, I think that is going to have some real profound implications for the Medicare program going forward. And then what about the future of the program? Well, the saying is that the only thing that's constant is change, right? So more changes coming. I think the pace of changes is accelerating. We're going to see more changes faster. As a general observation, again, really good lunch conversation about this. Excuse me. Medicare is obviously a political solution to a political problem. And so it is both kind of embedded in the political economy and drives the healthcare economy a lot. And I'll provide some data about what I mean by that. And then finally, I grew up near Chicago. My dad is a White Sox fan and I'm a Cubs fan. So there's plenty of room for healthy argument among people and plenty of room for optimists and pessimists. So you can sort of see this as a glass is half full or a glass is half empty, or it's not a glass, it's a vase. So there's plenty of room for everyone's ideation about this. Go ahead, Risa. And then last, and as I said, this is really the most important thing, is just questions and answers. So please remember the program is being recorded, so PG. If we don't know, we'll try to go find out for you. Opinions are not facts, but we're happy to hear your opinions as well. So I'm aware, I've been doing this long enough that they won't be questions sometimes. They'll just be commentary or observations or personal experiences, and that's welcome. We prize civility and respect. Like try to have a civil discourse, and humility and perspective and humor are gold. Coin of the realm, right? Okay, Risa. So let's talk briefly about the Insurance Commissioner's Office and consumer protection. The commissioner, as he said, is a separately elected official. The Office of Insurance Commissioner was written into the state constitution because it was understood what a profound effect insurance has on the economy and on people's lives. And consumer protection is our number one responsibility. We have a formal consumer protection division, and that's my group, but really the rest of the organization is organized around this idea of consumer protection. So we have a group of folks who are engaged in political activity and legislative work, some that we introduce and some that we respond to. We review and approve rates and forms that the insurance companies use. So this is one of the ways that we try to help, make sure that no one is being exploited and that the rates that insurance companies want to charge are justified by their experiences. We license all of the agents and brokers in the state, and we also supervise continuing education programs for them. And significantly, we handle complaints from consumers and educate consumers about their rights and protections and options, including for the SHIBA program, but also for the part of the business that we regulate directly. Thanks, Risa. So about SHIBA and consumer protection, the only part of the Medicare business, so to speak, that we formally regulate is the Medicare supplement plans. But we're heavily involved in the rest of the business that we don't regulate. As the commissioner said, we don't have the deep pockets of the Humanas or the other big insurance companies of the world, United Healthcare, but we really want to provide an alternative forum for questions and answers and an alternative point of view. So we take a lot of pride in being unbiased and confidential, obviously free support for you. Typically, when we have a one-on-one appointment, I'm pointing to my friend in the back of the room who did a SHIBA volunteer in Massachusetts. A typical appointment for us, if you sit with someone like Tess or one of the volunteers, is about 45 minutes. So it takes a long time to kind of unwind your story and make sure we really understand your concerns and, present to you a full range of options. So, we kind of have no skin in the game. We don't receive a commission or any other form of compensation. So it's really just about helping you get to the best decision for you. And I think one of the things I'm hoping to do today a little bit is just provide some context, right? I'm a strong believer that all of you have lived rich, full lives and raised a family and had a career, bought a home, managed investments. You can figure out Medicare. So I think sometimes it's just about helping you to kind of apply your native intelligence to a problem that might not be familiar. There is certainly lots of jargon. It's a little bit of a foreign language, but I'm confident that you can do this, and we're here to help you. Can we go one more, Risa? So how we do our work is a lot about through individual advisors that are trained by my staff. And we also engage a number of local partners in the community. So we refer to these as in-kind partners. So they're typically professionals who work at organizations like hospitals or clinics, schools, area agencies on aging, and we provide some education and support to them as well, because it's a place that lots of seniors go for services or go for help. As the commissioner said, we staff our toll-free number, 1-800-562-6900. During business hours, it's live answer all the time by a trained staff. They love their jobs and they're great at it. And right now, I think when I talked to my friend Daniel, I think we had 388 calls on Monday come in. And this reflects kind of the surge that happens around Medicare open enrollment. We become about half of all the inbound calls to the whole agency are about Medicare during the 6 or 8 weeks that we do Medicare open enrollment. And we do have a live chat feature as well. So you can kind of essentially do instant messaging with us if you want to ask a question online. We have an excellent website. We have a terrific webmaster and a dynamic public affairs director. So you can use the website to order publications or download publications or just get some basic reading direct. You can also do some transactional things like file a complaint directly there or submit a question to the commissioner that will be answered by him or his staff. And we also are the Senior Medicare Patrol Agency. So if you have concerns about fraud, we would certainly want to talk with you about that. Or even if it's not, maybe it doesn't rise to the level of fraud, but you're confused about medical billing, we'll be happy to answer those questions for you. Can we go one more, Risa? Okay, contemporary challenges. So right now it is Medicare open enrollment time. It is the time that you can make changes to your Medicare insurance. Obviously, technology helps, and a lot of people either don't have access to high-speed broadband technology or don't feel comfortable using it. And again, our volunteers or staff would be happy to help you with that. We don't want technology to be a barrier to you getting the help that you need. I talked just for a quick second about the Inflation Reduction Act. Most of the media attention related to that has been about the government's future, not yet, but future ability to negotiate prices for some drugs with the manufacturers. But there are some real important short-term changes coming. Starting in January, the out-of-pocket cost for people who use insulin will be capped at $35 a month, which is still a lot of money, but a dramatic savings. There are lots of people who spend $5,000 or $10,000 or $15,000 a year for insulin and related products. So that is a really important short-term benefit. As well, we've standardized the features of Medicare Part D plans with regard to things like the upfront deductibles. Some things that maybe have received less attention, maybe less newsworthy, but I think very important, are that we have expanded access to oral health care and mental health care and preventive services in Medicare. So starting in January, all of the routine kind of vaccinations that you might want or need will be free of charge to Medicare beneficiaries. So regardless whether you're in the original Medicare program or a Medicare Advantage plan, no more co-pays for vaccination. So I would certainly urge you to consider a flu shot, a shingle shot, obviously COVID vaccination. So please keep current with your vaccinations. In terms of mental health care and oral health care, Medicare still has a long way to go. Dr. Hamm and I talked about this at lunch. The commissioner has been, as John said, a great advocate for consumers in Washington State. And we have probably the most progressive stance with regard to mental health parity in the country, so that companies are going to pay for benefits for mental health essentially at the same level that they pay for other kind of healthcare services. The Medicare program has not caught up to us yet, but the significant change that will happen next year, and this is about expanding access, is that some folks who have a credential like a clinical social worker will be able to practice with less direct supervision from psychologists or psychiatrists. So it's a small step, but it's a bit of a recognition that more and more seniors are struggling with serious mental health issues, which has always been the case, is starting to get a bit more attention. With regard to oral health care, obviously what people want is the kind of insurance for dental care that they had when they were working. And that probably, sadly, is not going to happen in your lifetime. So let me just kind of condition your expectations here a little bit. But Medicare will start to provide more, especially screening services, so that if you are a person who, your oral health care is going to compromise your overall health care, we want to make sure that we kind of identify and arrest problems earlier on. So it's worth taking a minute to read about the changes that are happening with regard to preventive care benefits in the year ahead, because they just don't attract the kind of headlines that other changes do. Telehealth is here to stay. Obviously, we're returning to something more like normalcy in terms of people going into their doctor's offices to be seen, but Medicare is going to continue to support telehealth, which is important for everyone for all kinds of reasons, but especially for seniors who live in rural or frontier areas where transportation can be especially challenging. And as I said, the public health emergency crystal ball will be ending in January. And this is important for Medicaid. So we have Medicare and Medicaid. For Medicaid, because for about, 2 years now, we have suspended redeterminations of eligibility for Medicaid benefits. So we've essentially, people who were eligible at the start of pandemic have been presumed to continue to be eligible. So now the states are going to go through this long-term effort about recertifying people. And with due respect to my friends at the Department of Social and Health Services and the Healthcare Authority, this is going to be a train wreck. and clients will not understand what they're getting, and they're not going to get enough of what they need. And so our volunteers, again, are going to kind of step into that breach and try to help. Can we go ahead, Brisa? Okay, this is obviously my slide about the effects of the global pandemic. I'm convinced that the trauma that people have experienced is real and profound and persistent. You might not know, but COVID deaths are the #3 cause of death for the past 3 years. Obviously, still heart disease and cancer outpace COVID deaths, but it has eclipsed all other causes of death in the country. So it just feels important not to underestimate the impact of the global pandemic here in Washington State. And as I said, I think this will have, I'm starting to stray now into the realm of opinion, right? I'm still in arm's reach of the facts, but now I'm starting to stray a little bit. I think this is going to have profound effects for the Medicare program as we see folks who are long haulers or even short term. The impacts on Medicare, I think, are going to be a big deal. And beyond that, on a more personal level, we have just a tremendous more than expected number of widows and widowers. And so this is going to just amplify what was already, a pretty profound concern about mental health and elderly with isolation and depression. Suicide in elderly is not a thing we talk about, but it's real. And so I just think we should, all be prepared to bear witness to the suffering that other people are having and help them reach out and get the support that they need, please. Okay, so what about the future of Medicare? And now I'm like 2 arms lengths away from the facts, okay? But first thing I would say is that Medicare, although we act like it's always been with us, is a relatively new program. Medicare was signed into law by President Lyndon Johnson in 1965, took effect in 1966. So it's only been around for about half a 100 years. And we don't talk a lot about Medicaid, but Medicaid was another important Great Society program that came online at the same time as the Medicare program. It's important because, I would say for 2 reasons for us today. Medicaid is for one reason, almost 20% of people in Medicare are also enrolled in Medicaid. So in other words, they're eligible for Medicare insurance because they're over age 65 or they're younger disabled people. And at the same time, they qualify for Medicaid because they're living in poverty. So they have very low income and very limited assets. So this is actually 1 in 5 people currently and growing and expected to grow. And so if you think that navigating Medicare is complex, navigating both systems is more than twice as hard. So Medicare is a complex program that is not going to get easier. Can we go ahead one more? So this slide is really kind of for context. So on the left-hand side, I'm showing you overall federal spending. And the blue colored kind of piece of the pie represents discretionary spending. Discretionary spending in this regard means that there has to be an appropriation by the Congress in order for that money to get spent. So it goes through that kind of, the commissioner is going to have to school me on the way home, 10 or 12 committees that have jurisdiction over the appropriations, compared to what I'm calling mandated spending, which means that it goes on unless the Congress takes action to suspend the appropriation, right? And then so on the right hand piece of the pie, then I've unbundled the mandatory spending to show you how much of it goes to Social Security and the Medicare and Medicaid, and then the orange colored to my eye, orange-colored piece of the pie is other income-related children's health insurance program, basic food, what we used to call food stamps, supplemental security income. So the sort of bottom line here is that all by itself, the Medicare program is 13% of all federal spending and growing. So, right, it's a big deal, right? It's a mountain of money. Can we go ahead one more, Risa? Okay, so it is, as I said, Medicare open enrollment time. And the reality is that most seniors don't do anything at all during Medicare open enrollment time. So there's a thing called the current beneficiary survey, where Medicare asks people about their experience of Medicare. And in the last cycle, only 3 out of 10 people did any comparison at all about what I have today compared to what else is available in the marketplace. And most of those people are the ones who are enrolled in Medicare Advantage plans. And mostly what they're doing is looking at different plans that are offered by the company they're already enrolled in, right? So I have United Healthcare, but there's 19 other United Healthcare plans. Maybe I'll take a look at one of those. So there's a very limited number of people who are doing any kind of meaningful comparison shopping during the one time of a year that they get to make a change. For the small number of people who did, kind of engage this, and as Jack and I said at the lunch table, it's a formidable challenge. It's not a thing to take lightly. It's not like binge watching Netflix. This is a thing that takes a certain amount of attention and concentration. Only about 1 in 10 actually made a change in their insurance. So great news if you're an insurance agent, right? Because you're just cashing that commission check. But probably less good news for consumers, because there probably are other options that it's worth at least taking a look at, because your needs are changing over time. And again, as with kind of shopping in general, most of the people who changed are on the Medicare Advantage side of the world compared to enrolled in the original Medicare program. Conversely, our experience in SHIBA sort of bucks this trend. Almost half of the work that the volunteers do all year long is during the 6 or 7 weeks that is the Medicare open enrollment period. And whereas for Medicare beneficiaries in general, the most likely people to compare and the most likely people to change tend to be more affluent people who live in urban centers and are white. Our population goes the other direction. So most of the clients that we're helping are lower income people with less education who live outside city centers, which I think is a good thing for us. That really is sort of our target population, right? We're looking for the people for whom a conversation with us would be the most impactful in terms of their social needs and financial needs. And certainly we would never turn anyone away, right? We want to help everyone who wants help. But I think the point is, sort of the deck is stacked against people who don't already kind of come to the table with some native experience that they can bring to bear, or the resources to navigate the system. Can we go one more, Risa? Okay, Medicare Advantage plans. Medicare Advantage plans get tremendous amount of headlines all the time, and they deserve it. And so here is my simple graphic about 4 things that I'll talk about briefly during the presentation, and obviously you'll have a lot of questions after the fact. So the first graphic is showing the trend line. What's happening in general with Medicare Advantage plans? And right now we're almost at 50% of all people in Medicare are enrolled in Medicare Advantage plans, and that trend is going to continue. The Congressional Budget Office forecast is that we will pretty quickly move from about 48% to about 62% across the next decade. So, whatever your feelings about Medicare Advantage plans are, they're here to stay. That is the future, and that's the second graphic. The third graphic is that a reality about Medicare Advantage plans is that are concentrated in urban areas. So if you were to take a look at a map of Washington state and where are more people enrolled in Medicare Advantage plans compared to original Medicare programs, it pretty well tracks with the I-5 corridor and then the city centers like Spokane or the Tri-Cities in Eastern Washington. And that has a lot to do with the kind of economics of how Medicare Advantage plans work. And that has a lot of consequences in terms of kind of a representational democracy that I'm sure we'll have a good conversation about. And then the last graphic is that there is a real concentration in the market between United Healthcare and Humana, they have more than 50% of all Medicare Advantage enrollment is in those two insurance companies. And it'll be interesting to see, what kind of what happens with that trend. Obviously the other insurance companies are not sort of giving up the ghost and walking away from the market. But that's the reality of kind of where we're starting from. We're starting from a somewhat unequal place. Okay, a couple of other things that, I wrote this program kind of anticipating conversation that we might have. You all represent a relatively more intellectual audience than I typically address. So I'm giving you kind of the graduate school version of the program today. So a couple of things that, again, receive a lot of attention and maybe on your mind. And they're different, but they're both also related. So the first is technology. So technology in all forms is just galloping ahead. And this, I think, is the prime mover behind my earlier observation that the pace of change in the Medicare program is accelerating. That's largely driven by technology. The second reality of what's happening out there in the world, although private equity is a somewhat vague expression, what we mean is that folks are investing in healthcare in ways that are pretty unprecedented. A lot of money is flowing into buying hospitals, doctors' practices, technology businesses. And that, I think, is also a trend that is going to continue. And again, with respect to Dr. Hamm and others who practiced in the field, the landscape for doctors is very different than it was when Dr. Hamm graduated. Pretty well gone are the days of solo practitioners or two guys in a practice where they own the practice and the building and the technology. For the most part now, these are either investor-owned or co-owned, hospital-owned, but that's kind of where we're starting from, and my forecast is that's where we're likely to continue to be at. Whether that's sustainable, we'll see, right? That's a bit of a guessing game. In the short term, it's a pretty lucrative investment, but I don't know. There's going to reach a point of diminishing returns, in my view. Right? Can we go one more, Risa? I'm almost at the end here, so get ready with your questions. So equity matters. I started my career in state government working in the Office of Insurance Commissioner for Commissioner Kreidler. I'm a huge fan of the commissioner. And I say that even when he's not in the room, and even though he is my boss, it's sincere. It's not just flattery. And he has had a long-term principled, effective focus on equity. He and I rode up together, and I was recollecting for him when, there was a challenge about Primera becoming a for-profit company and what to do with the disposition of this vault of money that they had. And, his intervention made a meaningful difference. And across the years, he has sponsored or led a number of initiatives, including women's right to access for reproductive care and equality of access for transgender people. And so it's a privilege to work in the office. And I think that all of the drama that's in the world outside also shows up in our office. It's just a remarkable time right now that we're living through. And it's going to be an interesting challenge to the Medicare program, how to deal with the changes that are happening in demography. Because the population of people who are turning 65 is the fastest growing part of the population. And the next generation of people who are turning 65 don't look like, sound like, move like the people who came before them. And that's going to be a profound challenge for the Medicare program in terms of policy and for the program in terms of administration. And as long as I'm the SHIBA program manager, that's my principal challenge in terms of organizing our staff and our outreach. So just one data point that I think is emblematic of some of the changes that we're witnessing is that a couple of years ago, for the first time, and this has persisted, more women are graduating medical college than men. And again, this is 2 arms length removed from the truth, right? But I think that that trend will continue. And I think the reality is that whenever women come into a profession or become the predominant people in a profession, it changes the profession altogether. And so I think that the advent of more women doctors is going to profoundly change how medicine works. And I think that is just one way to think about what the future holds for us. It makes me feel hopeful and optimistic, but other people may experience it differently. And Risa, do I have any other slides? I don't think so. This is just the slide where I say, if I repeat or paraphrase or foreshorten your question, it's just so that the rest of the audience can hear it as you intended it, and for the folks who are online. And Barry, you're going to work a walk around mic? All right. Thank you very much for your attention. How about questions?
I really applaud the mission you have, and I'm just wondering how to deal with the fact that you're putting your finger in a dike where oceans of money are being spent to inform or misinform people. We're fortunate to have a university-sponsored health plan, which is Medicare plus a supplemental insurance. That's it. But everything is pressing towards Medicare Advantage, as you know. And we see full-page ads from United Healthcare saying, if you're having trouble getting into Polyclinic or Everett, we can help you out. We'll give you an Advantage plan. And I noticed that most of our providers are Polyclinic. If you go on the Polyclinic website, more and more doctors are Medicare Advantage only. Not all of them yet. So there apparently is some pressure or motivation for doctors to do that. And it leaves people like us out. Polyclinic used to be an independent facility, and then it sold itself to Optum, and Optum is owned by United Healthcare. So, we see huge budgets being spent, as you say, on maddeningly diverse ads. And you're doing a great job, but what are the chances that any of that could be regulated?
There's a couple of questions there. Thank you. I want to answer both of them, but let me just make sure, Commissioner, if you want to address any of these questions, please feel free to help me out here.
Well, it's interesting to raise that particular question about the plethora of information that's being dumped on people, and obviously they tend to be they have very pointed reasons why they're advertising, and they want you to come in and see them, and they're going to direct you to their products, even if it isn't the best choice for you. That's gotten the attention of Congress and the administration. President Biden has spoken on it, and it is going to be a topic before this next Congress about putting some further ability on the part of state insurance commissioners to be able to press the issue of making information available in an unbiased fashion, so that they have a balanced approach as to what the choices are, not one that's going to be skewed toward a particular product. So I'm looking forward to perhaps seeing some of that come through the process. The other is, some of that advertising has been outright deceitful and dishonest. It is not directed in a fair and equitable fashion. And that is something that has gotten Congress's attention too. So both by we don't have any control right now over Medicare Advantage. We do, unlike the Medicare supplement programs, which we administer, we have no control whatsoever over Advantage. we effectively have to take your issues and complaints and refer them to Health and Human Services and for them to take the issue because we don't have regulatory. That's something that Congress is going to be looking at to make a change in that regard. But I particularly like the idea that they'll be looking at that advertising because, quite frankly, I like Joe Namath as a football player, but not necessarily as a hitman for the industry.
Thank you. I'll just add, I think what that sort of vertical integration, if I could use that expression, those of you who, studied history, kind of remember the time of the robber barons, right? And we're going to have trust busting and other kinds of interventions. That sort of vertical integration has a lot of momentum right now, right? So CVS, right, which you used to think of as kind of your local drugstore, now owns the insurance company Aetna, and right, and so you're going to continue to see, this pretty epic battle, right, between CVS on the one hand and Walgreens on the other hand, and Humana on the one hand and Aetna on the other hand, and yeah, so I'm not sure if I'm not sure if I'm bought into the little Dutch boy with his finger in the dike analogy, but I think I was the one in my house was the Cubs fans. My dad was the White Sox fan. It took us 106 years, but we did win the World Series, and so I'm more on the optimist side of this. And I think what we have going for us is the person who says, hey, that's really interesting to the agent or the broker or the advertisement that comes in the mail or on email or the robocall. That's really interesting. I'm going to talk to my friend, Mary, who is a SHIBA volunteer, because I want to hear a second opinion. And I think ultimately that's how we will carry the day is the person who just takes that pause break before they sign and says, there is an Office of Insurance Commissioner, and there are these good-hearted volunteers who are well-educated and unbiased. So I think ultimately we will carry the day, because I think ultimately people know who's reaching into their pocket and who's reaching into their heart. Mm-hmm. Hi, Medora. Hey, Barry. Oh, Barry's going to come around.
I'll be there. Sam, would you
Hi.
lower your?
Yeah. Hi. First, I want to thank you and your group for what you are doing and what you're doing for us today. It is really, I think you are making it very clear, it is of critical importance. And it's very clear that the issue now transcends Medicare Advantage specifically. And that Medicare Advantage, I mean this as a question. That
Sure.
Is it fair to say that Medicare Advantage has been a step by United Health, now the company I was just mentioned, Polyclinic, the company that owns Polyclinic. Polyclinic is now a for-profit medical establishment. And that's the drive of all these insurance companies. They begin, it seems to me, they're beginning with Medicare Advantage as the stepping stone to creating, through the insurance companies, the takeover of healthcare. And it's going to be, their idea is all privatized. My question is that right? I mean, do I have a correct understanding? Not that we know it's going to happen or not, but do I have an accurate understanding?
Oh gosh, that's a good question. So for folks on camera or in the audience, how I heard the question is, are Medicare Advantage plans just kind of the next iteration and something else is coming behind it, but the long-term trend is towards privatizing the care that we receive and kind of amplifying the profit motive. Is that a fair appraisal? Yeah. So yeah, I mean, I think it's the advent of the Medicare Advantage plans, that was the Balanced Budget Act, right, that President Clinton signed. I think it was both meant to kind of arrest this kind of the trajectory of spending in the Medicare program, right? Because when it was a exclusively fee-for-service model, it was very difficult for the government, except through things like fee schedules, which again, the commissioner and I talked about this on the write-up, it just looks a lot like the wage and price controls, right, of the Second World War. And so it's a bit of a blunt instrument. And so I think that the, part of the impetus, if you will, for the Medicare Advantage plans was to say, in terms of global spending, here's a way to try to slow this inexorable rise in spending and appreciate that, we live for, physician practices are embedded inside a kind of medical capitalism, right? And so we could, in effect, leverage competition and say, gosh, if there's more, if there's this many doctors in Miami, I'll bet we could get them to compete with each other and drive a lower rate, right? And that's why you still, 20 years later, see this kind of concentration of Medicare Advantage plans in the places where there's a concentration of providers, because we can induce them to compete with each other for a lower rate. But then I think, yes, I mean, your observation is absolutely right. On top of that now are coming bigger fish though, right? They're saying in effect, well, after that has happened, let us go back in and see if we can drive even further discounts and have some of those profits accrue to us as corporate America. So I don't think it's a wrong analysis. I guess that's the point. Whether that is in the long-term best interest of the Medicare program or you as a consumer, I think depends a lot on how much does it tilt towards monopoly, right? I know you're wearing your Dodger blue. I appreciate that. Hi, Medora.
Hi. Say, what about insurance companies? Some insurance companies won't pay very much unless the doctor is a preferred provider. Could you talk a little bit about that?
Sure, absolutely. So the question was about what about preferred provider organization arrangements? And I would say that that expression and that arrangement was it predates Medicare Advantage plans, and there are now some Medicare Advantage plans that are called Medicare Advantage PPO plans, right? And so they're a bit of a hybrid, right? So to some extent, they're managing your access to specialty care, but they still give you some degrees of freedom, but it's constrained, right? And so the thinking is like, if there are, mostly this is specialists, if there are specialists who will take a lower rate in exchange for the insurance company driving more traffic to them, right? They'll trade a little bit on the unit price to get more units. That's essentially how a PPO organization works. I think, and Jim, I'm looking at you, Jim stepped away. Jim and I were talking at lunch about, one of the sort of positive effects of technology now with, if I could call it the modernization of physician practices. In the beginning, the PPO organizations were a lot about who would take the rate. It had very little to do with the quality. And I think a positive thing that we've seen over time is that the Medicare agency in particular has gotten much better at using their own data and disclosing the data to researchers and academics. And so we have a much better line of sight into what drives quality, and we're starting to see more money move towards rewarding quality. The other thing that gets a lot of headlines, again, the commissioner and I, the last time we went out together, we went to Edmonds a month ago, was right after the big story in the New York Times about companies or companies that help companies with technology and upcoding and potentially fraudulent billing and risk adjustment, and whether companies were trying to make people look sicker so that they could accrue more reimbursement from the federal government. So that's a thing that needs a lot of investigating. It's really hard to do sort of an apples to apples comparison, right? A common question is like, on average, do Medicare Advantage plans save the government money? That's a very difficult analysis to make. But I think that there is a positive drive towards getting better data about quality and outcomes. And I think that's for the positive. I think, frankly, it also is contributing to why it's so difficult to be a small physician practice, because the cost of the technology, it can be prohibitive. And then the skills to use it. So this is a bit of a double-edged sword, I think, but yeah.
I have a
Please.
question. And I think you have touched on it a little bit just now. Is there any way that we know whether when the practices have sort of moved towards private ownership of hospitals and physician practices, do we have any way of knowing how that's related to quality of care of the patient?
I would, so I'm going to try to restate the question. Like how good is the quality data in terms of whether these consolidations or doctors joining into multi-specialty clinics, whether that's actually improving outcomes? Is that a fair way to say that? I would say we don't have good data. I would say the data in that regard are still pretty green and pretty suspect. But I would say that that's an object of a lot of attention by a lot of people. I would say as far as Medicare goes, probably them sort of dipping their toe in the water, so to speak, is that they've been working very hard for several years now to get better data about outcomes in nursing homes. So if you go to the Medicare website, they have a pretty good nursing home compare tool where they accumulate the quality data. It's easier for them to get because the nursing homes are more regulated than physician practices are. So I would say, no, I think you can be skeptical about someone saying we get better outcomes than somebody else does, especially when doctors overlap more than one practice or more than one insurance. Again, with respect to Dr. Hamm and others of you who practiced, I think that the tools that the doctors have now are helping to improve quality. And I think that's a positive outcome. And I think we just have to be careful that it doesn't constrain their professional judgment. Can I say that? Okay.
Are all Medicare Advantage plans, do they all have the same benefits?
No.
All right. And is there a document that shares those differences?
Not easily.
Could
you want to keep going?
Yeah. Could you provide us a resource where we can find that?
Yes. Yes. Okay. We landed on yes. So yes. So the in the back of your Medicare and You handbook that you all, presuming you're enrolled in Medicare, that you all got in the mail, there is a kind of review of the Medicare Advantage plans and special needs plans that are available in Washington. It has a pretty high level review about what are the benefits in this plan. Barry, that does not count as a drop the mic moment. Sorry. But our office, we have access to a little bit more landscape of plans data. And so we produce, and you can find this on our website or you can order it. We produce a slightly more comprehensive list of, take top 10 benefits: hearing aids, dental care, transportation, optical, vision, and for the plans, is it covered? Yes or no? What's the deductibles, co-pays, co-insurance? It's still limited though, honestly, in the way that we don't kind of drill down as far as like, do you have to go to Vista Optical to use your optical benefit? Just because the provider, and this is a perennial challenge in the commissioner's office, tracking provider networks and the adequacy of them. It's very difficult for us to keep up with that. So all the data are filed with CMS. So the Medicare Advantage plans have to file all of their provider networks, covered benefits, rates, medical loss ratio. But that's just to get started. When January comes, they start amending things, right? And so it's as if, when you signed up, this was the formulary, but we reserved the right to change it. So in January, we don't pay for XYZ thing anymore, or that pharmacy is not part of our network anymore. So I'm somewhat teasing because we had lunch together, but that's why it's not an easy yes. Because it's a bit of a moving target.
On your website, there is this kind of information.
Yes. Yes. What is the website? Risa, I think I have a slide that has the website, yes? Oh, goodness. See, that's how old I am. I'm not a website person. Tessa's a website person. It's the OIC, it's at oic.wa.gov. Is it the last slide, Risa? I need a better editor. Oh, phew, okay. So for us, it's SHIBA at oic.wa, but the general website for, we actually do regulate other insurance. So if you have questions about homeowners insurance or a life insurance policy or annuity.
But for Medicare, is it shiba.law.gov?
That you can, on that website, Jim, there's a big button that says Medicare. Yep.
Change the subject.
Can you all broadcast the website? Is that possible?
Yes.
Risa says, I don't know. Hey,
We can put it in the alert.
that'd be grand. Thank you. I'm embarrassed I don't know. Yeah. You can order online. You want Barry to come over here?
Is there any data comparing the US costs of Medicare or medical services or medical benefits to a single payer plan such as Canada with respect to quality and cost? Is there any good data comparing them? And is single payer off the table in the US?
Wow. Do you want to help me with this one? We cost more than everybody. We always have, and we always will.
Why always will?
It's just that's our political economy. Right? We as Americans, like, too much is never enough. With regard to single payer, that's a more interesting question. I wrote my master's thesis about the role of the American Medical Association in blocking a national health insurance program in this country, where we literally had doctors, in private appointments with people telling them to write to their Congress people and say, we don't want this. I'm not sure that's ethical, honestly. But no, I don't think single payer is off the table. But, John and I talked about this at lunch. I think that, the reality, in my opinion, is that doesn't mean that we don't continue to have a large corporate presence of the Humana, United Healthcare, whoever comes behind Walgreens and CVS. It's not incompatible to have single payer financing, but still have, a strong presence of corporate profit motivated companies. That's not exactly what you want to hear, I know, so I apologize. But no, I don't think single payer is off the table. I mean, there's just, there's a lot of efficiencies in it, and it does generally drive better quality. It's certainly better for equity. So I don't think it's off the table. That's just a question of political will. I'm a sort of amateur, historian of healthcare issues, and you all would have been, contemporary professional when we were awfully close to having a national system of health insurance under President Nixon. We had 3 or 4 bills that were in the Congress, and Senator Kennedy wanted to be more wanted to be president more than he wanted to pass one of Nixon's bills. And so it didn't happen. But, you know, we were close. So I don't think it's off the table at all.
Sir?
Let me just say that Winston Churchill was right. Trust the Americans to do the right thing after they've tried everything else. I mean, just look to the Canadians. They spend substantially less than we do. Their health statistics for as a country are substantially better than ours. And they spend substantially less than we do on a per capita basis. And yet we have a substantial number of Americans that still don't have access to health care.
Come on, John, let's have a question.
Over here.
Hello. I
Hello.
have a question regarding the acronym ACO REACH, and wondering if that means privatization of all of Medicare. I have, there is a group here in Seattle, the Retirement Association, that were kind of publicizing that this would be privatizing all of Medicare. Is this true?
Not true. So you can rest easy in that regard. And what ACO REACH means, the ACO part means Accountable Care Organization. And so the Medicare agency, which is the Center for Medicare and Medicaid Services, CMS, is very committed and still committed to what they're calling patient-centered, value-based strategic purchasing. So it is about trying to drive better health outcomes and to make payments more attached to quality and to kind of rationalize the, you know, the payments that are happening. So remember when I said that, you know, 1 in 5, 20% of people are in Medicare and Medicaid, that will be a principal focus continuing for Medicare, because those are the very most expensive people in Medicare. They're the most likely to have comorbid conditions, for instance, or serious healthcare conditions. And so in general, this, you know, the initiative is about finding ways to provide better quality at less cost by focusing on, you know, the small number of people who are the biggest drivers and suffer the worst from kind of the fragmentation of the system, right? So when Medora asked about PPO organizations and other kind of managed care organizations, you know, the promise of those is better coordination of care. We don't necessarily get better outcomes if an ordinary person like me manages all their own referrals, because it can get pretty fragmented. So having, whether it's a primary care physician or a care coordinator, we have this expression health home, where someone is kind of helping to manage your care. That generally does lead to better outcomes. So the thrust of the ACO REACH program is really about just trying to capture data and use it to help manage specialty care. So it's really not about privatizing the system, but back to my earlier slide about technology and private equity, it has proven profitable for private equity firms to invest in that technology, and for practices to essentially earn more reimbursement by having the appearance of a relatively less healthy population group, right? So in other words, if you said this practice, on average, it costs $500 per person, and this practice, it costs $600, over time, Medicare will move the rates, right, to try to make it more right. And so some private equity firms see into that sort of essentially an arbitrage opportunity, right? They're going to be faster at the data than the Medicare agency, and maybe potentially drive up the reimbursement rates, but I wouldn't equate that to privatization of the system. And there was tons of feedback to the Medicare agency about that, and they've sort of rescaled what ACO REACH looks like. But in general, things like accountable communities of care are here to stay for sure. And I think that I'm off your question now. But I think the other thing that you will inevitably see is the Medicare agency is going to try to figure out, as will the Medicaid agency, try to figure out how to provide services and provide compensation based on the expression that they would use are what are called the social determinants of health, SDOH, right? So it's in effect recognizing that some people are predisposed to cost more, to need more services because they're starting from a relatively disadvantaged place. So that the common conception might be somebody who experienced a lot of trauma earlier in their life, and that affects their health and how they use healthcare on a going forward basis. And there's a sense that we should recognize that, treat it, and pay for it. So I think that's going to be the next iteration of something like ACO REACH. Is that on point to your question? Okay. Hi, John. Thanks for waiting.
This kind of hypothetical questions. Somebody mentioned a polyclinic here earlier. So just as an example, since polyclinic is owned by United Healthcare now, and they push the Advantage plans and so forth, would somebody under the original healthcare with the supplement, would they, something like the polyclinic, would they have a reason to treat them differently than somebody on the Advantage plan? I'm not saying that that's done, but what do you think about that?
Well, I mean, thanks for acknowledging that it's a bit of a speculative question. So, I'll say my personal attitude is that there certainly are some bad actors out there, right? I mean, there are some unethical doctors and institutions, but I continue to believe that should not keep us up at night. That when we show up for an appointment, I think we can have confidence that that person is doing their very best for us, independently of their reimbursement. So what I believe is that the average physician, Dr. Alemu at the polyclinic, she's not going to treat you any different depending on your insurance. Having said that, it is true that they, as I said earlier, they may be constrained about what they're able to do, right? But and this could be a practice agreement, or this could be an agreement with the insurance company. But they may not. It may not be easy for them to refer you to a certain specialist, or to prescribe a certain drug, or to spend as much time with you as you feel like you need. But I don't think it affects kind of clinical judgment. Is that on point to your question?
Somebody with a supplemental plan, like something like the F plan, which is long, or the G plan, which is pretty.
Thank you.
There are many Medicare supplemental plan versions of that, but somebody with the old F plan or G plan, which are pretty generous, I'm just speculating that it might be to their advantage to do more treatment or provide more for those people than the people with the Medicare Advantage or with the lower grade of the supplemental plans.
Okay, thanks. I got it that time. So I think I would answer that in two parts, John. So I think the first thing is that the question, and back to the question about the PPO organization, in a fee-for-service world, like a original Medicare supplement, Plan F or Plan G, really the more the doctor orders of anything, or the more return visits you make, the more their income, right? It's a pretty straight line relationship, whereas that's not the case like in a Medicare Advantage plan. So, whether it would affect a doctor's judgment about inviting you back for a follow-up visit because effectively they're not going to get reimbursed for it. I mean, again, my instinct is that doctors it would not affect their clinical judgment. Yeah, but I think you're absolutely right about that is the way the incentives align. Yes, for sure. Okay.
Hello, thank you. You may have addressed this. I was upstairs and came down, and maybe during that time, my voice is challenging because of a recent stroke. So I
can hear you fine.
Thank you. So I'm now 75. I'm a younger portion of this audience. When I was 65, I signed up for Medicare and I used Brandex. When I was 66, I went to a seminar and a fellow was presenting about United Healthcare and their zero premium program. I was enticed by zero premium, and he talked about the government gives capitation for that. I don't understand how people like me could pay zero premiums and have it work out. Where does the money come from? I guess us taxpayers, but I don't understand how. Now that I had my stroke after 10 years of zero premium, I'm surely getting all my money's worth from 2 huge hospital bills.
Thank you for the question. Did you want to address this one? No, thank you.
The zero premium capitation.
Zero premium capitation. Yeah, I mean, capitation is such an unfortunate expression, right? Because it's like, but yeah. So it's a great question. It's an important question. I'm gonna try to answer it briefly, but your instinct is exactly right. You are paying for it. I mean, the bottom line is you are paying for it. So who is my timekeeper? Risa, how much time do we have? Couple more minutes. Okay. So the zero premium plan, effectively what that means is that the insurance company is getting so much money directly from the government that they don't need to get it from you in the form of a premium. That the rate that they're getting from the government is rich enough that they can offer you a zero premium plan. Okay, so one of two things, and again, remember my earlier observation that all of you have enough native intelligence to solve all of these problems. If something seems too good to be true, it's too good to be true, right? So if Mary is in a plan that doesn't charge $0 premium, one of two things is true. Either they're not as efficient, it costs them more, or they're just making more money than your $0 premium plan. In other words, if they can get Mary to give them $10 for what they have to get zero to get you, they will do it, right? Why would I offer you something for zero if I can get you to pay $10 for it? So it's about competing to get you enrolled into the plan. In the same way that the gym membership is, every year, my beloved mother calls me around this time of year and she says, I know we have this conversation every year, and every year you tell me the same thing, stay with my plan. But my friend at Water Aerobics has this plan and it pays for her gym membership. Shouldn't I go there? No, you should not go there. You should stay right where you're at. Remember last year and the year before and the year before. So we wouldn't call it an inducement because that has like a legal kind of connotation. But yes, what's happening, literally happening, is that the insurance company, say United Healthcare, is reimbursed a per person per month amount for everyone that chooses United Healthcare directly from the government. And it's enough money for them, based on the contracts that they negotiated with the doctors and the hospitals, to make a profit without requiring a premium from you. Yeah, you're exactly right.
Okay, I'm afraid this is an afterthought, but not uncommonly. Could you comment on the insurance coverage for mental health and behavioral health, services, and do you anticipate any changes in the future?
Yeah, this is something I feel very hopeful about, Jack. In general, it's poor. It's very unfortunate. I think we continue to stigmatize mental illness, which I think is super unfortunate. And yeah, I think that you will see over time the benefits that and Medicare in particular offers improve. The challenge, honestly, is just that people are so skeptical that therapy works that they don't want to pay for it.
Yeah.
So in effect, the burden, and I'm not suggesting this is reasonable, but the burden is on the provider community to say it's safe and effective, it makes a difference, it's worth paying for, because there's just a public skepticism about that. But if there is such a thing as a silver lining to kind of the difficulties that we've been living through, I think it has raised people's awareness about how urgently we need to take obviously severe persistent mental illness, right, of schizophrenia, bipolar, but also just the profound anxiety and depression, especially in seniors. So I think the only thing that will complicate this in effect is there are not nearly enough providers, and they're not distributed in anything like a reasonable way, right? Which is a very rational choice on the part of providers. But in general, it's very difficult for bureaucracies and for Medicare to say, we're going to pay for a benefit that you can only get if you live in Seattle, but not if you live in TWISP, right? Because the people in TWISP are going to say, well, what about me? Right? Which is a fair question. And the answer is, let's put more practitioners there, or make it worth their while, or reimburse it through telehealth. But yeah, in general, I do feel. Mhm.
I had one last comment. I emailed some of my friends this morning to see if they had any questions. One of them, I will refer to your office. It's not quite appropriate here, but one of them was that she made the comment for 2 years. She's been trying to get Regents Advantage to reimburse her for the hearing. So she called Regents. She just texted, I called Regents again, and they really jumped through the hoops when I told them you were talking to the state insurance commissioner today for me. I think the problem will be resolved, 2 exclamation points. I was given the, in quotes, in caps, personal number of the insurance claim rep who was helping me on this case, and said to always call her in the future. Early bird doesn't get the worm anymore. It's the expletive squeaky wheel.
Well, I think if it's okay with Risa, that's a good place for me to step down and let the insurance commissioner take the credit, because it actually does matter. Our intervention does matter. Will you come forward?
Oh, I'm going to end it. So, okay. Thank you very much, Tim and Mike, for coming here today. And as I think it was you, Tim, you said change is the only constant. So we'll remember that and try to keep up with our learning about Medicare. And thank you so much for the SHIBA program. I learned a lot, and I hope that we all did learn about Medicare today and into the future, where, which is always uncertain, but thanks again. Yeah.